So welcome to this webinar. We will wait a few seconds more. We see more people joining. So. Okay, I think we should start now. So hello, my name is Lennart Turfjell. I'm CEO for Diagnostics. Very warm welcome to this webinar around Dementia MRI interpretation towards quantitative assessment. We have two speakers today, Professor Fredrik Barkhof. I will introduce him in a second. And then we have Dr. Jyrki Lötjönen, the Chief Scientific Officer at Diagnostics. And if we look at the agenda, we will start with visual read current practice. Then Jyrki will give an overview of quantification techniques. Then we will review a number of clinical cases. And we will end this webinar with a Q&A session. Please, if you have questions, type your questions in the questions tab in the chat window. You can do that throughout the webinar, of course. So whenever you have a question, please go ahead and type it. So if we go to the next slide. Now it's a great pleasure for me to introduce to you Professor Fredrik Barkhof. He's Professor of Neuroradiology at Amsterdam University Medical Center and University College London. He's a well-known key opinion leader in the field and the author of several textbooks in the area. So without further ado, Fredrik, the floor is yours.
Yeah, many thanks, Lennart, and welcome to everybody. Thanks for joining in this session. I will start off, as Lennart says, by going through a little bit what radiologists encounter in daily practice and how you can approach imaging analysis in a structured manner and by deconstructing the images into certain areas where you can give visual rating scales, scores. And then pave the way for Jyrki to see whether we can perhaps improve on that using quantification. And so, just to for fun, I put up this old slide, which when I was trained, it worked that way. But obviously nowadays we do everything with a computer. But I don't think the attitude has changed much in terms of deciphering the patterns of atrophy. So here's a clinical case where I showed you some cuts from a scan, which is always a bit unfair because, in reality, the task is much more complicated because you have a whole, you have perhaps 5 or 10 sequences, each with 20 or 30 images. So you have to find the right images. So I've picked them out already for you. And obviously in dementia, the coronal images are really important to look at the medial temporal lobe, including the hippocampus and the parahippocampal gyrus. More anteriorly, the amygdala, but also the remainder of the temporal lobe, which are affected in Alzheimer's disease, but for example, also in frontotemporal dementia. And increasingly, I also pay attention to the more posterior areas of the brain, especially this area called the precuneus, and the corresponding interparietal sulcus that you can see on more transverse cuts, which is something that is affected, for example, in patients with posterior cortical atrophy. So that's an umbrella term, describing a clinical syndrome with visual spatial disturbances, mostly due to early onset AD. And in Amsterdam and also here in London, we see increasingly younger patients at memory clinics who may have completely normal hippocampi, but in fact have quite severe posterior cortical atrophy. So they have a slightly different pattern of atrophy. and also different imaging manifestations. So the typical Alzheimer pattern is that that you see in textbooks is the medial temporal one. We have hippocampal atrophy, memory problems, and these are usually relatively old patients who are ApoE4 positive. Whereas, in fact, these posterior pattern that I described, or posterior cortical atrophy, involves more the posterior areas of the brain, and these people tend to present more with visual spatial disturbances. They're usually younger, and they more often ApoE4 negative, although this is not as black and white. Sometimes you have older patients that have more this pattern, or you have younger patients that still present with the medial temporal atrophy. Even more confusing, we now also know that there are frontal variants of Alzheimer's and occipital patterns, really difficult to recognize or to correctly classify on imaging, because there's clearly a differential diagnosis. And also their symptoms may be quite different. For example, the occipital one may have more visual symptoms like you have in Lewy body dementia as well. So when we analyze images, we need to look for patterns of atrophy. And I'm showing this slide from work that I did. It was a collaboration between Amsterdam and London, where we pulled together cases who came to post-mortem, who had an in vivo imaging, about 160 cases in total. And then we did a voxel-based morphometry analysis to compare the density of gray matter between people with dementia and without dementia for various groups. It's a bit of a busy slide, but at the top you see Alzheimer patterns. So the typical pattern is this one, is late onset Alzheimer's disease, where you tend to see mostly atrophy of the medial temporal lobe structures, as I was just explaining. Whereas in young onset, also early onset Alzheimer patients, you see much more diffuse pattern, but in fact the more posterior part, the precuneus and the parietal lobes, are most severely affected. A bit similar to what you can see in people with mutation carriers with presenilin-1. So these are people with familial AD. They also have more posterior type of atrophy. Then the disease that is really disappointing for radiologists is Lewy body dementia, where you see very little atrophy compared to normal aging. And you really need a DOT scan to be able to make a diagnosis. And then at the bottom you have 4 patterns of frontotemporal dementia, depending on the type of mutation that they have. So, for example, in semantic dementia with the TDP43C mutation, you see very selective involvement of the temporal lobes, more on the left than on the right. But there are also more diffuse frontal patterns of atrophy that may occur with free repeat tau. So these patterns all convey diagnostic and sometimes genetic information that we should be on the lookout for. And to be able to go through a scan in a systematic fashion, I think it helps to use visual rating scales. Because first of all, it forces you to go through it in a systematic manner, to always look for white matter hypertension, to always look for the medial temporal lobe atrophy, to always look for posterior cortical atrophy. But it also provides a common lexicon. So otherwise you get rather vague statements like there's a moderate amount of atrophy or severe amount of atrophy. And people use these words differently. And by using rating scales and getting some training or education on how to apply them, we can sort of harmonize our language. And when we say an MTA scale of 2, hopefully we all mean the same. So the Fonseca scale, I'm sure many of you are aware is a simple scale developed by Franz Fonseca to describe the occurrence of punctate vascular white matter lesions in grade 1. And if there are more of such lesions, they can start to form little bridges, which is called early confluent, and then it becomes a Fonseca's grade 2. And when the lesions are confluent and you cannot recognize the individual lesions anymore, or there's one big lesion anyway, then you give it a score of 3. And this is a very relevant scale because with aging, you always have a few of these punctate lesions, but that is really not that important. It's important to pick out the ones with Fonseca's 2 and 3 because they are at increased risk of cognitive decline, but they're in fact at increased risk of dying from all-cause mortality, including diabetes, kidney failure, heart failure. So they're also just an expression of pure bad cardiovascular situation of the patient, which needs attention in general, regardless of whether this is combined with Alzheimer's disease or not. Then to describe the atrophy at the convexity, there's a simple global cortical atrophy scale, and this methodology of the 3 stages comes back in various scales, you will notice. So 0 obviously is normal. In grade 1, you will see some opening of sulci, but the volume and the thickness of the gyri still looks relatively preserved. Whereas in stage 2, you start to see that the gyri become a bit thinner than they usually are. And then in grade 3, they really become very thin, almost knife blade-like, as you can see over here or over here. So this is a general global cortical atrophy scale, and a similar variant of it we developed for posterior cortical atrophy, the PCA scale or the Kudam scale, where again, grade 1 means that you have a bit of opening of sulci, grade 2 that the gyri become thinner, and grade 3 that the sulci are really wide and you get a sort of knife blade appearance of the gyri. Can be done in a combination of slices. I personally like the sagittal or parasagittal slices a lot, but there are also patients where this may be relatively normal, and then the atrophy is better appreciated on the axial slices here, the interparietal sulcus. And with some training, you can also recognize it quite well on the coronal slices, but it's slightly more difficult to orientate yourself how far back you are in terms of being in the parietal lobe. In the postmortem study that I just described to you, we also looked at the correlation between various rating scales and the amount of gray matter that was left in the brain. There have been a couple of scales described to look at frontal atrophy. I'm not going to go into them in too much detail. They're illustrated over here. Sufficient to say that they do correlate with the gray matter density in the appropriate region, but some of them only very weakly, so they're probably not very useful. Whereas the posterior cortical atrophy scale, for example, if you give a higher score, then the volume of gray matter really severely goes down in the precuneus and the more lateral parietal regions. The same is true for the medial temporal atrophy, which I'll discuss in a second. If you have a higher score, MTA score, you have a very specifically reduced volume of gray matter in the hippocampus and the surrounding structures. So the latter two are really very specific scales. They really capture the pathology well if you do a volumetric analysis. So here's the medial temporal atrophy scale that I'm sure that many people are familiar with. I took an example from a paper where we applied this to CTs and MRs, people who were scanned on the same day with MR and CT. So this is one subject, this is another subject, here's the third one, and here's the fourth one. And again, this goes from 0 and now to 4. So 0 obviously is completely normal. Grade 1, you have a bit of opening of the choroid fissure, which is helpful for CT because then now finally you realize where the hippocampus is. In grade 0, you don't know where the hippocampus is because it's all one blur. This is still a normal situation. And then it becomes abnormal once the temporal horn starts to widen, the choroid fissure becomes wider. And then subsequently you get widening of the collateral sulcus and further widening of the temporal horn and disappearance of the hippocampus in stage 4. Relatively simple scale. So what is abnormal? Below the age of 75, an average score of 1.5 is abnormal. So that means you have to have 1 on one side and a 2 on the other side. So if you don't have a score of 2 on either side, it's normal. So as I said, the score of 1 is always normal, and a 1 and a 2 can be normal if you're really young. But if you're close to 75, then it's abnormal. If you're over 75, there's a bit of more age-related atrophy, and then you need a 2 on either side before you can call the scan abnormal, which obviously is arbitrary. And I'll come back to this point of arbitrariness in a second. If we measure the hippocampal volume, then you can see it's actually a bit more gradual. So here's where we measure the volume in controls and AD patients. And you see in the controls with normal aging, you have a decline of the hippocampal volume. So this is the average hippocampal volume, which is around 4 cc's, which declines with time. And you can see that the ADs have a similar decline, but the whole line has shifted down. So a young AD patient is already worse than an old healthy control. But you can see there's some overlap, and that's why we need to look at multiple regions to make an ultimate diagnosis. So what are the advantages of these MTA rating scales? I already mentioned that, we have a common language, which is more objective than using words, which we all use differently. They're quick, easily, and you look at the images anyway, so it's quick to apply. Need a bit of training, and I've put some stuff online on the radiologist assistant and also the books that I mentioned. It does depend on the scan protocol. I always look at them on a coronal T1, which is slightly angulated, so that you're perpendicular to the long axis of the hippocampus. But please always stick with the T1, because on a T2, the CSF looks brighter and you think there's more atrophy. And for example, on a flare, the hippocampus looks bigger because also the choroid plexus then becomes high signal. So it depends really on which type of imaging you use. One drawback is the lack of subtlety, because we can only have 0, 1, 2, 3, or sometimes 4. But sometimes you think, well, this is really a 1+ or a 1.5, which in fact I sometimes put in my report. I say that the atrophy MTA score is 1 to 2 on the left, and just more than 2. So you can use it a little bit in words, but it's not very subtle. And then the biggest point is the age dependency, which does apply to volumetrics as well, of course, but certainly the cutoff that we have at the moment for 75 years is arbitrary. So we did a survey among ESNR members to ask how many people were using visual rating scales. And a couple of hundred people replied, and 75 of them said that they used them with some frequency, especially the Fonseca scale is relatively widely used. So the green means always and orange regularly. So let's say 80% will use this sort of regularly. Similarly, for the medial temporal lobe atrophy, it's a popular scale. But then you can see that, for example, the PCA scale is less well known, less well used, and the global cortical atrophy scale is a bit in between. And so it's variable, and that has to do with the confidence, I guess, that people have. And only a small percentage of people is really confident about the use of them, and others have some level of competency, but there are also people that are not confident at all. And when you ask, what is the problem, is that, people said, I don't have training, or it takes too much time, or they don't know how to interpret it. There are various reasons why it's not universally adopted. Nevertheless, in the survey paper, we did say that, if you do some form of structured reporting, this is a possible way to do it. Obviously, always describe the vascular pathology, include a Fonseca score, describe the atrophy pattern, including a medial temporal lobe atrophy score, and then any lobar pattern, could be PCA or anything else, and always say something about infractentorial atrophy, for example, in mesencephalon becomes atrophic in PSP. And then obviously you have to integrate this information and come to a conclusion where you have to take age into account, and then the conclusion can either be normal, vascular, neurodegenerative, or mixed. And if it's neurodegenerative, it's good to provide a differential diagnosis in the appropriate setting. So if you don't know nothing about the patient, I would be really careful to say that the picture is typical for Alzheimer's disease, because the patient could just come with anxiety. So make sure you do this in the appropriate context. But what is the more difficult part for the conclusion is to take the age into account. So I have an MTA score of 1 and 2, so 1.5. Is that normal or is that abnormal? And so then, in fact, you have to go back to your internal database of what you've seen before and what you think is normal or appropriate for age. And that is a really difficult thing and requires a lot of experience. And that's why I think quantification in combination with normative data can really help us in difficult cases, which brings me to the next speaker, Jiki Lechera.
Thank you very much, Fredrik, and we will hear more from you when we look at the clinical cases. But now over to Jyrki, so we can hear a bit more about MRI quantification technical aspects. So,
Okay, thank you, Leonard. I will talk a little bit about this quantification tools, and first this kind of overview of the whole process. So first, of course, you need to acquire good quality MRI images. Then we segment the image and we do quality control for detecting any artifacts in the image. And thereafter, you are ready to quantify the volumes or other imaging biomarkers. And for example, for this patient, hippocampus volume left is 2.9 milliliters. But in order to make the interpretation easier, so then you need to normalize this data to intracranial volume, age, and sex, and then contrast it with normative data. And typically, this kind of percentile curves are used, what you see on the bottom right. And for this patient, this 2.9 milliliters, it corresponds to 5th percentile, meaning that 5% of healthy people of same age, gender, and head size, they have smaller hippocampus than our patient, indicating that actually the value is very atypical or abnormal. But of course, in a clinical practice, the question is that what might explain this finding? So what could be the reason for this? And then in the bottom middle, you see actually two distributions, and now we are contrasting this to different diagnostic groups. So blue one is healthy controls, and the red one is Alzheimer's. And we clearly see that our patient fits better to Alzheimer's distribution. But as we heard, there is hippocampal atrophy also in frontotemporal dementia, and distribution looks almost the same as in Alzheimer's. So basically, you need other imaging biomarkers to do differential diagnostics between FTD and Alzheimer. And of course, in a clinical practice, clinicians, MRI is just one piece of the puzzle, and they combine neuropsych test results, CSF biomarkers if you have available with this imaging data. And on the left bottom, you see there the result when all data is combined, and red indicates Alzheimer, blue indicates FTD, and clearly this is more pointing to Alzheimer. And actually, this patient got Alzheimer diagnosis 1 year after this data was acquired. So the next slide, please. A few words about the segmentation methods. Of course, it's not necessary to understand, the user doesn't need to understand all details, but it helps interpretation to have an idea how the method works. So there are plenty of methods, and I give 2 examples here. So multi-atlas segmentation means that we have a set of atlases. Atlas means that you have a grayscale image and then the manual segmentation for that image. Then you map that image to the patient image using like a deformation or warping, and then you propagate those labels to the patient image. So if you have 3 atlases, you get 3 segmentations. And then finally, you combine these segmentations to form the final segmentation. Then another technology quite widely used nowadays is convolutional neural networks. There basically, you take a large number of previously segmented images, and then you train your neural network to recognize different characteristics in the image, so that related to those segmented regions. And here you see, for example, segmentation of white matter hyperintensity, lacunar infarcts, and cortical infarcts. Next slide, please. Okay, now when we have a segmentation, then we can quantify many things. So typically people quantify volumes, but of course you can quantify many other things like those shapes or angles or textures in the image. And as we heard that in dementia, you have different kind of patterns of atrophy, so you can develop methods for detecting those atrophy patterns, or even you can develop a method which directly estimates the possible diagnostic group for the patient, like whether it looks like Alzheimer case or whether it looks like FTD case. So here we see a list of the imaging biomarkers with calculating our senior CMRI tool. So volumes, but also some specific imaging biomarkers. So let's take a couple of examples of those specific imaging biomarkers. Next slide, please. We heard about the visual rating scales, and in our tool, we estimate those computationally. So 3 scales. Medio-temporal lobe atrophy is estimated using hippocampus volume and inferior lateral ventricle volumes. Then global cortical atrophy is estimated using voxel-based morphometry. And then fasciitis is estimated using the volume of deep white matter hyperintensities. So on the right, you see that how well it works in practice. So horizontal axis are visual ratings from 4 memory clinics, and the vertical axis is the like a computational rating. And as you can see, the agreement between visual and computational rating is quite good. Then another imaging biomarker, if you take the next slide, please. Is anterior versus posterior index, which is a C-score that measures the relative atrophy in frontotemporal regions shown by red color in the picture, and then parietal occipital regions shown by blue. And on the bottom there, you see the distribution of this imaging biomarker in different diagnostic groups. And what you can observe here that clearly FTD cases have much smaller values than the other diagnostic groups in overall. And if you check that how well you can separate FTD from AD and take patients younger than 75 years, you can get like a 0.50 sensitivity, 0.99 specificity, and overall accuracy is 93%. And the next slide, please. And then finally, let's take a quick look to how all these imaging biomarkers, how they work in differential diagnostics. So first, let's look at the controls, how the controls can be separated from dementia cases. And as you can see, there are plenty of good imaging biomarkers for that, volumes, as well as there's like a computational MPA or GCA. Then if you think about the vascular dementia, then clearly it's either this fasciitis, computational fasciitis, or directed white matter hyperintensity volume that works like very nicely. Then for frontotemporal dementia, you see clearly the best values we get for this anterior versus posterior index. But as we heard already previously, that the dementia with Lewy body, that's a tricky thing, and especially AD versus DLP, you see that we get only 69% accuracy using hippocampus for that. So, but in overall, you see that actually these imaging biomarkers, they provide useful information for differential diagnostics in dementia. So now I give floor back to Fredrik.
Yeah, thank you, Jyrki, for this excellent explanation of how the tool works. So I'm going to show a couple of cases, 3 from our own memory clinic and 1 from the ATNI study that you're probably familiar with, to illustrate, how this works in real life practice. So these are cases which just underwent our routine scanning protocol and were uploaded to the server of Senior process and then pushed back to our PACS, where we can then see the results. So I'm starting off with a 50-year-old woman who was referred to a memory clinic. She had a mild cognitive impairment, and there were some elements that that both the referrer and the assessing clinician in our clinic think of, could be either AD or FTD, because there was also some frontal lobe disturbances involved. So it was a bit unclear clinical picture, and we can see a scan that is clearly abnormal, with some atrophy in parietal region, but also in frontal region, and probably some frontal ballooning. So you tend to think more of a frontal primary process than of a posterior process, but clearly both are abnormal. There's also some hippocampal atrophy, as we will see in a second. And you can see that a lot of values are well below what you would expect for age. So overall brain volume is below the first percentile, which is grossly abnormal, and the gray matter as well, of course. And conversely, the CSF is much too big. And then we see an abnormal anterior to posterior index, which I'll come back to, and also note that the the total brain volume is below what you would expect for age. So you can see initially this slope is relatively flat, and then it progresses for this age. It's clearly below the 5th percentile. Then alongside you get this report, more printed report, which summarizes some of these findings as well. So this is the PDF version. The other one is something that you have to go look into the database, and will also allow you to see the overlays of the segmentations, which are in the PDF version they provided as a screenshot. And we can see the hippocampus outlined, and the hippocampus is clearly abnormal, which we can see here in the hippocampal volume, which is way off the scale. But also interesting, if we look at the medial temporal lobe atrophy score, it's really high. It's 2.96 on the left and 1.76 on the right. So that's what I said. You can be more subtle with a computed MTA score than if you have to do it yourself, because then you have to say it's probably 2 and 3, and here it can be 1.76, which I quite like. The Fonseca score is low, which is fine, only a few dots in the brain. And then here you see a display of where the atrophy is, the computed global cortical atrophy scale, where the atrophy occurs. And it's mostly in the frontal lobes and relatively less in the posterior lobe. And that is reflected in this anterior to posterior index that Jirki was talking about, which is very negative, meaning that frontal is much smaller than posterior. We did a CSF analysis in this patient, and the amyloid was normal. So that basically rules out AD, and also clinical follow-up became more and more evident that this was an FTD patient. So coming back to this index, you remember this is relatively normal even in Alzheimer's, and becomes abnormal in the FTD spectrum. Here's another case also in the FTD spectrum. It's a 63-year-old male with probably semantic dementia clinically. And then we see an imaging pattern that is consistent with that, with asymmetric hippocampal atrophy, asymmetric atrophy of the rest of the temporal lobe, and probably some posterior to anterior gradient as well, which is highlighted here already. I'll show you the report version of it. So there was some hippocampal atrophy, as we noticed, on the left, almost 2, and nothing on the right. And in fact, if you see the more than 1 point difference in MTA score, immediately start thinking of FTD in general. And then here we see the display of the global cortical atrophy over the cortex. So the left side is clearly more affected than the right, with the temporal and frontal areas involved most. The hippocampal atrophy here, the average hippocampus is just borderline because it's asymmetric, so it's really important to look at them individually, because the right side is normal, but it's only the left side that is abnormal. So also here, the AP index is very strongly abnormal, minus 1.47, so really the lower end of even the FTD spectrum. And clinically also this was confirmed at follow-up. Let's look at a slightly more subtle case. This is a 58-year-old woman who also presented with MCI. And this is a borderline scan where you see a little bit of atrophy in the posterior regions, presumably some vascular, punctate vascular lesions. If we look at the overall brain volume, it's lowish, but not very severely abnormal, and there's some indication that the parietal lobe is more involved than other lobes. Here's the report of that patient, where we can confirm that the hippocampus is very normal, with very low computed scale scores for the MTA, but also very normal volumes of it. And then if you look at the cortical display of the atrophy pattern, it's mostly in the parietal lobe, as we said. So this could be an early posterior cortical atrophy patient, but obviously not with a high degree of certainty on imaging. Although I felt slightly more confident seeing this on this cortical display than just eyeballing the images, where you're always doubting, is this too much for a 50-year-old woman or not? So the MSE was moderately abnormal, but then she didn't want to do a lumbar puncture. So we couldn't look for the amyloid, but we tested the ApoE4 genotype, and she was a 4/4, which is very rare, but that puts you at a very high risk for Alzheimer. So in the end, this was an early onset AD, also quite a rapid evolution over time. And the last case I'd like to show is an ADNI case, which was a progressive MCI case in the ADNI study, who came in with some hippocampal atrophy, as you can see, more on the right than on the left, but also some opening of the Sylvian fissure here and some atrophy of the temporal lobe. And here you can see that the brain volume is actually not too bad, the 13th percentile. But if we look in a bit more detail, you can see that the computed atrophy scale is also borderline. Hippocampus is borderline, but then if we look at the MTA scores, it's almost a 1 and almost a 2, which especially this one puts them at the 99th percentile, so that's really bad. So you have a combination of overall atrophy, but especially medial temporal lobe atrophy, which would be consistent with AD, also the pattern of a bit more posterior involvement. And this patient was amyloid positive, and after 2 years received the diagnosis of AD. So this was a very early AD case who then progressed. Because it was in ADNI, there was also a follow-up scan after 2 years. And within the CNeuro tool, you can then, if you have 2 scans, you can analyze both of them and look at 2 reports. But there's also a 4D, so a comparison made between the 2 scans. And you see then in red where there is tissue shrinkage. And you can see a lot of shrinkage happened around the hippocampus and with winding of the temporal horn, but also the ventricular system at large. And then here you can see the result of that the hippocampus was shrinking by almost 5% per year, whereas the whole brain was more on the 0.5 to 1%, which is probably normal aging, but the hippocampus is clearly not normal aging. 5% is a lot, even for hippocampus. Notice, by the way, that this tool also shows the segmentation of the white matter hyperintensities and the differences, which you could use for other diseases like MS, for example. So to sum up, what is the value of this volumetric analysis in dementia? I see it as an adjunct to support our visual interpretation, because in the end, it has to be our visual interpretation that is condensed into a report, but it helps to confirm them. So, for example, if you're doubting whether your MTA score is 1 or 2, and basically whether it's normal or abnormal, it can help you take a decision. It's more granular, so it's more subtle than the more crude scales, and it's sensitive, as you've seen, to early pathology already. So either early onset of the disease or younger patients. So I think personally it's mostly useful when you have less experience with dementia. I've seen personally hundreds, if not thousands, of scans, so I have a sort of relative good normative database, and I think I can account for age differences, but if you see fewer of them, I think it can be helpful to have a sort of second opinion and an independent evaluation of the degree of atrophy. Especially useful for me when people are really young or really old, when it becomes difficult to say whether it's already abnormal or whether the amount of atrophy, let's say in a 90-year-old, is still normal for age, or even for a 90-year-old too much. And to pick up subtle early findings, as I said, which may be difficult to discern on a near normal scan.
Thank you very much, Fredrik and Jyrki, for this presentation. So now it's time for questions and answers. We have some questions in the chat window here, and I will read them, but if you have additional questions, please just go ahead and type them in here. So we have one question here. to Fredrik. How do you see diffusion MRI contributing to dementia assessment, particularly with regards to vascular pathology?
Yeah, so in our dementia protocol, we have as one of the routine sequences is a diffusion, a simple trace diffusion scan, initially we had it as an optional thing, and we put it in. So I see a lot of them, but 99% are normal. The cases where it's useful is obviously for Creutzfeldt-Jakob disease, which is extremely rare, and then occasionally you will find a area of diffusion restriction related to an infarct, which is also a rare event, because even in patients with vascular dementia, of course, because if you scan them, right that moment, they're very unlikely to have a recent event. And then sometimes you have certain leukodystrophies like CSF1R mutations, where you can see foci of diffusion restriction. So to be honest, I think the relevance is limited, and I didn't go into doing quantitative type of analysis, which I think is beyond standard clinical practice.
Okay, thank you. Another question: in what situations are MRI follow-up scanning done in routine dementia? Is that very rare, or?
Yeah, relatively rare. So I think the most common situation is where you're doubting whether mostly in patients with suspicion of FTD, I think, or patients where there's a suspicion of Alzheimer, and then, for example, they're doing relatively well, and they have very little atrophy, to make sure, it's really a neurodegenerative process. One of the problems, for example, I showed you a case with amyloid in the CSF, and you'll think, well, that's a definitive proof of Alzheimer's. But in fact, if you find amyloid abnormal in the CSF, doesn't mean that you have Alzheimer's. You could be just normal aging, and you're just at a high risk of developing Alzheimer's. So it's also not a definitive proof of Alzheimer's.
Okay.
So mostly in the FTD spectrum, but it's really challenging, and it's often disappointing, I think, doing repeat imaging.
Another question here: how can you discriminate between hippocampal atrophy of AD and hippocampal squashing distortion because of NPH?
Yeah, that's a good one. It's really difficult. NPH is so there's a lot of confusion around NPH. I don't know whether it even exists, but I do realize that you have these people with enlarged ventricles. So if you have, let's say in general, if you have hydrocephalus, then obviously the temporal horn enlarges, and then it looks really frightening. So then either I don't give an MTA score at all, or I try to correct for it by looking mostly at the volume of the hippocampus. And I'm not sure whether you at Neuro have experience with that particular setting, whether the hippocampal volume is still reliable, but that's a really challenging situation.
Yeah. Then another question here. I have a question regarding the specificity and sensitivity of atrophy patterns on MRI with functional impairment on neuropsych testing. It's not totally clear to me.
No, well, yeah. So I think we have to then ask, sensitive or specific for what? What is clearly the case that if you have hippocampal atrophy, then you could have Alzheimer's disease, but we've seen already that hippocampal atrophy, for example, also occurs in FTD, and even more confusing, it also happens in a disease called hippocampal sclerosis, which is found in more the 80+ range. So you're never 100% specific. So it's always, I think, a combination of finding atrophy patterns in usually multiple regions, or excluding pathology in other regions, in combination with neuropsychology and laboratory findings.
Yeah. Okay, thank you. Then there is a question around, will slides or a recording of this webinar be available? And I think the answer to that is yes, and we will send out an email to all participants later. I think I'm conscious about time. We want to end on time, but I have a question, maybe a yes/no question. Do you think that follow-up scanning using MRI would become necessary when we will have anti-amyloid agents approved and in regular use, or
that is actually a quite likely scenario, because as you probably know, these especially aducanumab, but also various other drugs that are being evaluated. So aducanumab is an anti-amyloid drug that's being evaluated by the FDA at the moment and may receive approval in June. We will hear in June. But what it does, it removes the amyloid, but when you do it too quickly, you induce a side effect, which is called ARIA, which is manifested by high signal in the parenchyma or in the sulci. And if you have too much of it, you interrupt the dosing or perhaps stop the dosing for a while. Not all of these ARIA cases are symptomatic, but there will probably be some advice around if they get approval, it will be in the label, there will be some regulations, safety monitoring.
Okay, so I think we are, I mean, it's 45 minutes past now. So with that, I would like to again thank Professor Barkhof very much, and thank you, Jyrki, for the presentation. And thanks to all participants for listening in. And we will follow up with additional webinars, both on clinical aspects of MRI brain quantification, but also technical aspects. So please look out for additional webinars in the near future.
Yeah, and thanks for attending.
Yeah, thank you very much for attending all.
Bye.
Bye, everyone.